Hi everyone, I welcome you all to the Labs to Clinic series, the very special series of microbiology at the MedEd channel. I'm Dr. Anusha Rathi and I welcome you all to this very special series. Those of you who have joined us, please come and say hi in the chat box. Of course, I'm eagerly waiting to interact with all of you. So in this series, we've been trying to incorporate your knowledge of microbiology with your understanding of the clinics and the medicine aspect of microbiology. So we are basically dealing with a few infectious diseases that come our way. So today we are going to deal with a very important topic, that is surgical site infections. So mostly usually when the patients, they undergo any surgery, the site at which the surgery has happened, the site where the surgeon has placed the incision, that sometimes gets infected. And then what we are supposed to do, and what is a circumstance where you have to identify that such a thing might have happened, that you have to find out. So I will be discussing one such case where it was a surgical site infection which is non-healing, like they were trying many different antibiotics but the patient was not responding and the site did not seem to heal at all. So we will walk through all the incidences, what might have happened, how the surgeon was going to pick up that it is actually a surgical site infection, what were the mistakes that happened, and how the laboratory diagnosis or the microbiology lab helps in identification of all of these, and why it is supremely important to take microbiology consult or to work in close cohorts with the lab in your clinics in order to achieve the optimum patient result, right? So two important questions we are going to discuss. Also, surgical site infections is a part of the curriculum of second year MBBS as well. So when we read, hospital acquired associated infections, we read about surgical infections there as well. So we will be discussing briefly about the classification of SSIs, and one organism is going to be implicated in this case. And so I am going to give you the clues to lab diagnosis of that one organism, and let's find out if you can answer that and you can actually identify the organism, right? So clinical background of a patient is that a patient is a 70-year-old person. He's a 70-year-old man, and with poorly controlled diabetes. Okay, so one significant history is that he had poorly controlled diabetes. He underwent elective total knee replacement. Now total knee replacement is one of the is a very common orthopedic surgeries which is performed especially in old age patients such as the 70-year-old man here. And it is supposed to be a very highly aseptic procedure which needs to be conducted. So you can imagine that if it is a total knee replacement, then of course what is the my patient going to have? My patient is going to have an implant in situ. So what are we doing? We are giving him an implant. So now we have to be extra precautious. So two aspects are going to get covered now. Was it simply a surgical site infection, or is there going to be a prosthetic joint infection? Because what is happening in total knee replacement? You're replacing the actual knee with a prosthetic knee, right? So a prosthesis has been implanted inside the body of the patient. That also can get infected. So how do we find the clues to that, right? Initial post-operative recovery was uneventful in the patient. Patient underwent the surgery, everything was fine. He was sent home with the normal advice of taking care of the wound, getting the wound dressed in the same hospital, then not letting it soak, not letting it get wet, and all of the common precautions that after the surgery which are needed to be taken, right? Eventually, the patient was supposed to undergo, physiotherapy and start walking normally. But on the first visit, that is the day 7, which was after 7 days of surgery, the first time the patient was called back to the hospital for a change of dressing and assessment of the wound, there was a mild seropurulent discharge noted from the incision site. Okay, from the incision site where the surgeon had given the incision. There was slight erythema, means redness, but the patient had no signs of fever. So at this point, the surgeon suspected that there might be some kind of a surgical site infection which is happening at the site of incision. What did the surgeon do? He picked up a swab and he sent the wound swab for culture to the microbiology laboratory in order to see if any organism is associated with this seropurulent discharge, right? Then the culture simply grew commensals of the skin. The commensal flora of the skin was grown, and the lab reported that there is no significant pathogen associated with your patient sample. So simple empirical antibiotics were started. Because there were only commensals grown, so obviously antimicrobial susceptibility testing was also not performed for the patient. And basically what is this scenario? It is the most common scenario which happens, that you send some cultures and a significant growth does not come out. So you're left with actually no answers, that which agent is it that has caused an infection in my patient and how should I treat it, right? Very, very common scenario of the hospitals, this scenario that I've given you, right? So empirically the surgeon says, let me cover all the spectrums of infectious agents. So he's given a linezolid to cover the gram positives. He's given cefixim, which is a third generation cephalosporin, to cover the gram negatives, and also given a metronidazole to cover the anaerobes. Because this brings me to the discussion that what are all the agents which can cause infections in the surgical sites? Absolutely any organism under the sun, right? All aerobes, be it gram positives, be it gram negatives. So all the skin flora can also cause surgical site infection. Staph aureus, streptococcus group, very, very important. If it is any kind of abdominal surgeries, then enterococcus also becomes important. All gram negative bacteria are also very, very important. Anaerobes, super important for surgical site infections. So thinking of everything, the surgeon decided that let me give all the groups of antibiotics to my patient, because the culture report as usual is useless for the surgeon. This is a very common scenario. If talking from a point of view of a person who has attended microbiology lectures and is microbiologically sound, what do you think was the mistake here? What do you think was the mistake here? Was there any mistake at the end of sample collection or not? I will tell you that the choice of sample which was collected was wrong here. That is why when we keep talking about lab diagnosis of various different diseases, we keep stressing upon you should know which right cultures to collect and send. That is the end goal of reading microbiology at an MBBS level. You should know which test to order, what sample to collect. Here what was collected? A wound swab was collected. So the collection technique is not proper, because swab is never a good sample for pus cultures. So here this is actually a poor quality specimen. Poor quality specimen has been sent. So what is the type of report received? A poor quality report received. Simple. What should have the surgeon done? We will find out what is the appropriate culture which needs to be sent in such a case. Before that, let's look at all the key risk factors which could have been there. Key factors associated with discharge from a surgical site. So whenever you have such a patient after surgery who's having any kind of a discharge, either purulent, which is pus forming, or serous, what are the risk factors that can happen in such patients, right? So increased pain or tenderness around the wound, okay? So this can give you a sign that probably there is some kind of an infection at the site. Even if you see no pus discharge, even if there is redness and there is pain and tenderness around the site, which should have healed on its own by the time, increased. The word here is increased, okay? So of course there is going to be some pain and tenderness at the site of surgery in the patient, but if it is continuously increasing, not getting subsided on taking analgesics and all the painkiller medications, then it is a sign of worry. If there is any kind of erythema or redness or swelling that spreads and gets worse, so any worsening of the symptoms which is gradually increasing is your sign that probably something is wrong at the site. Warmth at the incision site because of all the inflammation, and we understand that the inflammation process leads to erythema and increased temperature or warmth at the site of any wound or any infection. Fever or chills. Now if it is a sign of systemic infection, that probably now the infection has gone deeper into the body and it is now leading to systemic infections, because when do we get fever? Whenever there is microorganism in the blood. The moment it comes to the blood is when your body produces the fever. So fever is actually a danger sign whenever we are dealing with a pus discharge from a surgical site, because then you know that this infection has now gotten deeper and it has gone deep into the wound and deeper parts of the body now, right? A foul or unpleasant odor from the discharge is a very big sign of a acute bacterial infection, and delayed healing with wound edges separating, which is dehiscence, right? Even if you don't find any frank pus coming out of the wound, but the surgical site, which should heal in a set number of days, it is not healing, and in fact you see dehiscence. What is dehiscence? It is the gaping of the wound. You see, this is the incision, this is the line where incision was given by the surgeon. The surgeon has put the stitches, and after the stitches the skin gets approximated like this, but what is happening in the middle? It's opening up. It's called as a gaping wound. Gaping means it's opened up. So gaping wound or dehiscence, non-closure, non-healing wound is the biggest sign that is telling you that some kind of a surgical site infection has happened in this patient now, right? What are the risk factors? There are mostly some patient related risk factors also. Some patients are more prone to getting infections at the surgical site as compared to other patients. Common ones are poorly controlled diabetes. So that was our case in the very beginning. He was already an old man who had poorly controlled diabetes. So we know that glycemic control of blood sugar during the time of surgery, after the surgery, in the recovery period is supremely important, because if uncontrolled glycemic control is there, a huge sugar spike is happening in the patient who's a diabetic patient and he's undertaken surgery, then it can be a big risk factor for development of a surgical site infection later on. Okay. Then obesity and high BMI, tobacco, smoking use, etc. Everything is pointing towards weakened immune system. So basically any immunocompromised state is going to be a risk factor for the patient to contract SSIs. Malnutrition, advanced age. So this is a risk factor in our patient. This is a risk factor in our patient. Pre-existing infections elsewhere in the body. So now you cannot just simply put everything on the patient, even though our patient had two of the risk factors, but then there are also certain procedure or surgery related risk factors which are associated. What are the surgery related factors? Prolonged surgical time. This is very important. So if you are a surgeon and you are taking a lot of time in conducting a surgery, the chances of your patient getting the surgical site infection keeps increasing with each passing half an hour. Why? Because you must have heard of something called as prophylaxis, antibiotic prophylaxis or prophylactic antibiotics. What are these? These are the surgical prophylaxis antibiotics, meaning when you take a patient in the OT and you start the surgery, before you give the first incision on the skin, you want any empiric antibiotic to have reached the skin site, meaning prophylactically, preventively, in order to prevent an infection later on, we give antibiotic infusion to the patient before we even give the first incision. What is the funda behind it? That the T half, you all know that the antibiotics have a T half. So this time of giving the first incision is decided on the basis of the T half of the antibiotic that you have chosen. Suppose you have chosen any cephalosporin, third generation cephalosporin as an antibiotic, which you are going to infuse into your patient before you take him inside the OT. You know that the T half of that drug is 30 minutes or 1.5 hours, meaning that or 5 to 6 hours, right? So you know that if the T half is 5 to 6 hours, then the peak concentration of that antibiotic is going to come in 30 to 40 minutes. So you know that the incision that you are giving in the patient's skin should be within 30 minutes of when you have given the antibiotic. Makes sense? So that when you are giving the incision, when you have opened up the patient in an environment where there can be many microorganisms, the peak amount of antibiotic is present inside the serum or the blood of the patient, so that if any microorganism comes in the way, it can be killed and can be taken care of. It does not lead to infection. And that antibiotics, because of its T half, it is going to get metabolized and passed out of the system of the patient. So if suppose the antibiotic you have given has the effect up till 1.5 hours or 2 hours, and your surgery continues beyond 2 hours of that time, then the antibiotic protective cover which you have given to the patient is lost. So that increases the chances that the patient is going to get infected by any microorganism which might be present in the OT, in the in the instruments, the surgeon's hands, wherever. They can come from anywhere, right? So prolonged surgical time is actually one of the risk factors. It has to be completed in a set time span so that the antibiotic cover that you have given to the patient can still be there the entire time when you open and close the patient back, right? Inadequate antibiotic prophylaxis. Your choice of antibiotic is incorrect. That choice has to be made depending upon which site of the body you are performing the surgery, what is the common flora which is present there, what is the most common organisms which can cause infections in these sites, so that you can appropriately choose the antibiotic. That is why it is very important to read systemic wise microbiology and to know all the organisms which can be implicated in different sites of the body. Because if you are giving a gram positive prophylactic cover in an abdominal surgery, that is not or in a joint replacement surgery, it is going to be it is a good decision for probably European countries, but for Indian setup where gram negative infections are much more common, then your patient is not going to be as protected, right? So that is how you have to choose the antibiotic prophylaxis. Most hospitals have their guidelines and dictums which decide it. So the surgeon has to stick to it. So two mistakes can happen. One, you prolong the surgical time. Second is the antibiotic cover that you have chosen was incorrect. There is gaps in asepsis or infection control practices. There is not no HEPA filters in the operation theatre. So there is outflux of air happening from the outside environment. So the environment inside the OT, the air inside the OT is unfiltered. Secondly, the autoclaving procedure or the surgical instruments that you are using, they were not properly sterilized. The sterilization controls were not put in place. That is why it is important to read the sterilization disinfection chapter, where we keep telling you the biological controls, which spores are used, which chemical controls are used. Why? Because when you're a surgeon and the instrument comes to you, it is also a moral responsibility of yours to pick up the controls and check and be assured that the instruments which are being handed over to you are actually sterilized properly or not, right? Secondly, the surgeon is not washing the hands properly. Hand hygiene compliance is not there. The procedure of wearing the gloves, removing the gloves, there is a gap in that. There is a lot of traffic inside the OT. Lots of patients are moving in, they are going out of the operation theatre. The doors are opening and closing repeatedly. Then the personal protective equipment, the OT dresses are being worn outside of the OT in common areas. All of these are commonly seen things. They all contribute to breach in infection control practices. Means proper infection control practices are not taking place. Therefore, you are not able to control the infection and an infection can happen inside your patient. Poor surgical technique or presence of foreign material, similarly like I said. So there can also be surgeon related, management related, procedure related, microbiology department related, infection control officer related gaps in the techniques of surgeries. There can also be patient related factors which can contribute to all of these can contribute to development of surgical site infections. So let's quickly look at the different surgical site infections. You understand that surgical site infection is any infection that happens at the surgical site. Now, what is the meaning of surgical site? One is incision site, the site where the incision has been given. The site where the incision has been given and the infection happens only up till the skin and subcutaneous tissue. Only the skin and subcutaneous tissue is involved, and at the site of incision the infection happens. We call that superficial incisional surgical site infection. This is category 1. The superficial SSI, superficial incisional SSI. Up till what time can you blame the surgeon for giving you this SSI? Suppose you had a surgery today. Here our patient, he started developing the pus after 7 days of discharge. But what if a patient starts to develop that pus after, let's say, on the 40th day or the next month of performing the surgery? Up till what time can you say that this is actually a surgical site infection which has happened inside the hospital, or because of surgical technique it has happened to the patient and not because of any other reason, right? It is 30 days. So 30 days after surgery, 1 month after the surgery of the patient, Within that period, if there is any pus discharge, erythema, redness, we have just seen pain, tenderness increasing, any signs of infection at the site of incision up to the skin and subcutaneous level, we call that superficial incisional SSI. Let's go deeper. Let's go up to the muscles and fascia. Still, but at the site of incision only, at the site where incision was given, we have gone deeper up to the fascia and muscles. We become deep incisional surgical site infection. Now the time period increases even more, 30 to 90 days after the surgery. So when the patient comes to you with this discharging pus, it is very important to assess the depth of the wound. How much deeper is the wound? From where up till which level is the pus coming? That is what the surgeon has failed to do over here. He simply collected what? He simply collected a swab from the wound. What is a swab? It's a very superficial sample. So there was no assessment of the depth of the wound. How deep is actually the infection? What is the level of the SSI which has happened? Simply from the superficial layers, the wound swab was collected, and swab is a very poor quality specimen because it dries out, right? So by the time it reaches to the lab, it dries out, and the pathogen, because we know that pathogens, they really need moisture. We have learned this in general microbiology. They cannot survive in dehydrated conditions. So the swabs, they tend to dry up very fast. So even if there is some pathogen, it will die and then it will not grow in culture. Instead of that, what will keep growing? The commensals which were there on the skin, because the commensals are always much more adapted to grow than the pathogens. The pathogens are always slow growing, and they are very, very fragile microorganisms, so to say, and the flora of the body is more hardy than the pathogens. So swabs are not at all good specimens ever. Here that assessment was not done, a poor quality specimen was sent. That is why any direction to the treatment could not be given, because the sample collection technique was poor here, right? Could have been one of the factors, or probably the lab failed to grow the microorganism or whatever. So the two scenarios that can happen, but intervention needs to happen at some point, right? Then second, the third is organ space. That is, we have gone deeper now. Now we have gone to the level of the organs. Organ space, bone involvement. When any of such thing happens, we call that organ space SSI. What is that? That is also 30 to 90 days after surgery. So after you have done the surgery, within the first month, if any infection happens in the skin and subcutaneous plane, it can be called as an SSI. After that, it is not an SSI. It means that some infection has happened which has just coincided with the site of surgery. If the infection happens in muscle or organ or bone level, then 1.5 months, 90 days, up to 90 days after surgery, it will still be implicated to the event of the surgery. That means you have given the infection to the patient at the time when you did the surgery, because it can take up to 90 days for the infection to develop in an organ space after doing the surgery. Okay, so it won't happen immediately. The organisms, they take time to grow. They take time to establish that infection. They take time to start producing the symptoms, and therefore up till 90 days, you have to keep a watch on these patients, right? So 3 important categories, 3 important questions done. What are the 3 categories? Superficial, deep and organ space surgical site infections, right? Then let's go back to our patient. The patient was, discharged on 3 antibiotics. The surgeon thought that, okay, fine, the lab report is not guiding me. I will give 3 antibiotics to the patient, which is a wrong practice in the terms of antimicrobial stewardship practices, where we say that you should have culture guided antibiotic policies. But here, since the culture was not very decisive, then the surgeon gave those. Now, the surgeon must have given the 3 antibiotics thinking that it will cover any possible, organism which might be implicated to this SSI. But that did not happen. The patient should have improved now. Irrespective of the report, the patient did not improve. There was worsening pain, redness and warmth. Now, copious purulent discharge has started, which was mild seropurulent to begin with. Now, it has become copious and highly pus. High amounts of pus is being formed. Low grade fever has now also started emerging in the patient. All of this is telling me that the patient is now worsening. In spite of giving all these antibiotics, patient is not improving, there is worsening of infection. Now, instead of sending a proper culture, what is a proper culture? We will find out, because the surgeon probably got, demoralized, thinking that, oh, never something never comes out of the lab report. Then the surgeon thought that, okay, it's very important for me to control the infection of the patient right now. So he decided to give a high-end antibiotic. So meropenem, which is a carbapenem, was added empirically. Still the patient worsened further. High-grade fever has now commenced and there is increased inflammation. Now the patient had to be admitted, because despite of giving very, very high-end antibiotics to the patient, the wound is not healing. The amount of pus discharging is increasing in amount. Physically looking at this wound, it is worsening, and also the patient is now developing fever. The overall condition of the patient is worsening. So of course now the patient has to be admitted, and now a very, very high antibiotic, colistin, has been started, and now they have decided to take a proper workup of the patient. It is generally believed that whichever infection it is now, since colistin is the most high-end antibiotic available to us, pathogen should get killed. Now you see so many antibiotics, patient is taking a gram positive, a gram negative, an anaerobic, a broad spectrum. Meropenem is a broad spectrum antibiotic. It works on a whole plethora of organisms, including GNBs and also anaerobes. Then colistin, which is the highest order of antibiotic, that has also been given. At least now the patient should improve. At least now the infection should stop. But we find that the patient continues to worsen despite giving so many antibiotics. So now the proper workup has been decided. So, let's just look at the list of the microorganisms implicated in PJI. What is a PJI? Prosthetic joint infection. We don't know now, because even despite giving so many antibiotics, and because now it becoming a systemic kind of a picture, probably the implant that you have given, the prosthetic joint that you have placed in the patient, probably that is also infected. So now you want to first have a knowledge, what are the organisms which actually can infect a prosthetic joint. So you have your gram-positive aerobes, such as your Staph aureus, Streptococcus, Enterococcus, and also certain important, cons, Coagulase negative staph or OSS, other staphylococcal species, which are a part of the skin flora, but if they are introduced at the time of surgery inside the joint, deeper inside the body, they can cause an infection, right? Then many gram negatives are also there. Gram negative bacteria, entire enterobacterial family, very common in India. Entire enterobacterial family. Pseudomonas, so common, so important. And a very recently arising Acinetobacter. There are so many gram-negative bacteria which can cause infections. Anaerobes are supremely important. How can you forget the Clostridium species, Clostridium perfringens? If this happens in your patient, this is absolutely bad news, because this is a highly myonecrotic organism. It is going to cause lots of tissue destruction and gangrene inside the patient. Then there is a very cute bacteria called Cutibacterium. Cutibacterium can also lead to this infection. Mycobacterium species, even though this is an acute presentation, this is within 7 to 14 days the infection is started, but mycobacterium such as your non-tubercular mycobacteria, sometimes even your Mycobacterium tuberculosis, can lead to infections in the prosthetic joints, means the implants that you have put to the patients. But these infections will happen as a chronic feature. After many months, they are going to present, right? Not so acutely. Now, any of these guys could have caused an infection in my patient. No, but every cover has been given to the patient. Something should have killed them. Now, proper sample collection is what is being done. So, orthopedic plus microbiology consult is now obtained, where the lab has worked in communication with the surgeon, and now we are going to take up the case properly. The lab will also do proper diagnosis and the surgeon will also send the proper samples. A deep aspirate of the pus is what is now collected, which is what should have been done in the first place. A wound swab is a superficial sample. We simply roll a swab stick on the wound and you send it. That is a superficial sample, and it is highly likely that the pathogen is going to get missed. What should be aimed or attempted every time is to take a needle and syringe and aspirate the pus from the deepest possible site. because that is going to give you the true picture of a true pathogen which might be responsible for causing this infection. This is now done, and a deep aspirate is collected aseptically, not a swab. What is the meaning of aseptically? That you don't have to think that if it is a wound which is infected, then asepsis need not be performed on the skin. That is not the case, because if you think performing asepsis on the skin is going to kill the organism which is causing the wound, then why do you need all these antibiotics? Simply rub Dettol on wounds, na, and everything should become fine. No, that is not the case. So even when you have an infected wound, when you're trying to collect the pus aspirate from the deeper sites, the superficial skin should still be aseptically cleaned and decontaminated, because otherwise you're going to pick up the normal flora of the skin, and that is why it becomes very, very difficult to extract the correct pathogen in the lab, right? Now it was sent for gram stain, culture and AST. Now they want to give a guided antibiotic susceptibility guided therapy wants to be given, because they have given every antibiotic under the sun. Still nothing is working. Now AST. So this is the wrong practice. If in the very beginning of the patient, the aspirate could have been collected and sent for AST, and the treatment could have been started in an AST pattern guided manner, what the antibiotic susceptibility test is telling you is the susceptibility and resistant profile of organism, then we can prevent a delay in diagnosis, and we can prevent the infection from spreading to systemic sites also. Then in the laboratory, we found that on the Mekong agar there were non-lactose fermenter colonies. So you know it can be a wide range of enterobacterials, it can be a wide range of non-enterobacterials, other pathogens such as Pseudomonas, Acinetobacter, Burkholderia, you name it, right? And it's a gram-negative bacilli. So we know the dictum, whenever we have a gram-negative bacilli, the first test that we perform is a catalase test, and I find that the catalase test has come out to be positive. Then the next best thing that we have to do is we want to place it under the enterobacteriales family. So for that we need to do glucose fermentation. It is telling me that the glucose fermentation test was positive. Nitrate reduction test is also come out to be positive. Right, so all the 6 features of a gram-negative bacterium, glucose fermenter, nitrate reducing, catalase producer, then you have to know whether it is, it is facultative anaerobe. So on OF test, we have find out that it is both oxidative and fermentative, both results are coming. So we know that it is, facultative anaerobe also. So all the features of your enterobacterial family has been passed. So you know it is some enterobacterial which is a NLF enterobacterial. So what other tests do you put? Of course, looking at here, you know, what are you seeing on this plate? You are seeing swarming. You are seeing swarming on the blood agar, where you can see the concentric circular growth of the organism. And here you can see that TSI is giving me what? Abundant H2S. Abundant H2S production. Citrate seems to be negative. That is not important to me. What is this test here? The green colored PPA, phenyl pyruvic acid positive. We know that the PPA positivity is the characteristic feature of the Proteae family. So up till here I know that this is some enterobacterial. This is some enterobacterial. And since this enterobacterial is PPA positive, I know that it belongs to the Proteae family. I have also now seen the swarming, and you see indole positivity, indole positive. So you remember the mnemonic VIP, vulgaris is indole positive. So I think it is Proteus vulgaris. Urease is also positive, which is also a feature of the Proteae family. And of course, you can see the swarming of the Proteus. Identification has now been made that the patient's wound got infected with the Proteus, and AST showed me a Pandrug-Resistant Proteus. That is what was the problem here. Proteus by itself as a feature leads to non-healing infections, because even if it is giving you a UTI which gets complicated, a UTI which is untreatable, despite giving antibiotics, the UTI is not getting treated, you should always think of Proteus. Any wound infections, ear infections which become malignant, fulminant, despite giving antibiotics, they are not treating, they are just worsening, you should think of Proteus. Because as a behavior, as an intrinsic nature, Proteus is a highly drug-resistant pathogen. It becomes even more important when it is acquired from a hospital setting, because in the hospitals we know that the MDROs, multi-drug resistant organisms, are very commonly found in the hospitals. Here what did the patient get? Very unfortunately, a pan-drug resistant. When do we call a pan-drug? When all the classes of antibiotics are resistant. You know, the organism is resistant to all the classes of antibiotics. So you can see carbapenems, beta-lactams, quinolones, aminoglycosides, colistin, tigecycline, it is resistant to each and every class of antibiotic. That is why nothing was working on the patient here. Also, you remember the mnemonic. Which are the guys which are intrinsically resistant to polymyxin B? We know polymyxin B is the class of colistin. Yes, it is in the name itself, poly B, P and B, two guys which are intrinsically resistant. Intrinsically resistant meaning that their lipopolysaccharide layer itself has a positive charge. So the colistin is not able to act on their cell wall only. So a high-end drug like colistin intrinsically never works on these two guys. What are the guys? P for Proteus and B for Burkholderia. So what is your learning from here? Giving colistin is not the ultimate big thing that you can do for your patient. There are agents which can lead to infections who are intrinsically resistant to colistin. That was the takeaway from here. Now, what do you do for such a patient? What do you do? Final diagnosis was a non-healing surgical site infection due to a pan-drug resistant Proteus, and whether it was a prosthetic joint infection or not, it still needs to be found out. So now the surgeon needs to explore and see if the implant or the joint, the prosthetic joint they have placed, is that also infected deep inside. So the patient needs to be taken back inside the OT, opened up and looked for a prosthetic joint infection. Also very, very importantly, was there a biofilm formed on the prosthetic joint? That is what is important here. That is what is of concern. You know that the biofilms can be formed on any surface, and these bacteria, almost all enterobacterials, have the ability of forming biofilms. So it's not that only Pseudomonas can form biofilms or Klebsiella can form biofilms. Any organism can form a biofilm. And the reason of most prosthetic joint infections is whenever there is such a bad condition of a patient where such a fulminant infection has happened in the prosthetic joint, sometimes biofilm has formed on the prosthetic joint, and then absolutely no antibiotic is going to work on your patient. So this needs to be assessed. Now the severity of the situation needs to be assessed by opening up again in the OT. So contributing factors could have been poor diabetes control. So at the time of doing the surgery of the patient, if the blood glucose was not properly monitored and kept in control, it all increases the chances of the patient getting a surgical site infection. Inappropriate first sample swab also contributed to the delay in diagnosis of this patient, because if the initial level of aspirate could have been sent, then we could have known that this is a drug resistant Proteus we are dealing with, and we would not waste time and money just prescribing all of these 5-6 antibiotics which were given to the patient. Empirical escalation to colistin without culture is also one of the contributing factors. Why? Why is this empirical antibiotics leading to worsening of the infection? Because what they do is they kill every susceptible organism there. Then the resistant ones, they become stronger under the pressure of all of these different antibiotics. Even if initially the infection of the patient was because of multiple infecting organisms and the pan-drug resistant Proteus population was smaller, you have given so many antibiotics to the patient that everything else gets killed. And the small population of PDR Proteus starts growing even more. And now you have a pure infection with a highly drug resistant organism. That is why just giving a high end antibiotic is not the correct way of dealing with the things, right? Sometimes it can cause more damage than good for the patient. What management strategy? Medical therapy is insufficient, maybe due to a biofilm. We are not sure whether it is there or not. It requires multidisciplinary management. So surgical debridement needs to happen here, drainage of the abscess and a removal of foreign body. Staged revision of arthroplasty might also need to be done. So all of this the surgeon has to assess inside the OT. They have a separate set of guidelines for dealing with prosthetic joint infections, wherein the surgeon is now going to take the decision. If I can continue with this implant that I have put inside, I have to completely remove the implant, let the patient heal, and then again revise and schedule a repeated total knee replacement for the patient, which in fact is a very expensive procedure. No standard antibiotic is available for PDR organisms. You have a few new beta-lactamase inhibitor group of inhibitors, such as your ceftazidime, avibactam, which is currently available in the market, which can be tried in this patient. And sometimes you can also decide different combination therapies where you can give aminoglycosides with meropenams, etc., depending upon selective susceptibility. But you can think of ceftazidime, avibactam plus aztreonam, which is what? Which is a monobactam. Then Cefiderocol, which is a 5th generation, Cefiderocol and some 5th generation cephalosporins, etc. These newer agents can be tried in the patients. You have to optimize glycemic control, and strict wound care and close monitoring of the patient is now required. So now, because of some pan-drug-resistant organism and not timely detecting the organism by sending proper sample collection, proper AST profiling and proper drug selection, you have lost a total knee replacement in a patient, right guys? So this was the interesting case, pressing upon the importance of proper sample collection, proper antibiotic therapy, lab report guided antibiotic therapy and antimicrobial stewardship, right guys? So this is all the places you can contact me in case you have any doubts. Thank you so much for attending. I always tell the students to just stay in the game and everything's going to be fine. Thank you guys so much for attending this session. Any doubts, do ping me. I'll see you next time in another session. Until then, bye-bye.